Okay, our next presentation will be by Toby Maher from London. The title of this talk is Profiling IPF, Rethinking Biomarker Discovery.
Excellent. Well, thank you very much, everybody. Thank you, Luca, for the invite and for organizing what's already proving to be an excellent meeting. So I'm going to be slightly more clinical than the last talks and talking about rethinking biomarker discovery in IPF. So this is the fourth Iclaf meeting that I've come to, and I think our understanding of disease has moved on leaps and bounds in that time. And we understand much more about the pathobiology, and yet when it comes to treating patients, this is still how I'm left feeling. And I think the reality is that we're not yet translating our understanding of biology into new treatments for patients, and I think there are a number of barriers to our doing that. So I thought I would cover them briefly. First of all, how do we define a diagnosis of idiopathic pulmonary fibrosis? So with the redefinition of the diagnoses back in 2001, we defined it as a disease related to the histopathological lesion of UIP. And yet, as we've applied this definition, we increasingly realize that UIP can be difficult to distinguish from the histological lesion of NSIP. We also see the lesion of UIP occurring in other diseases. So we see it in rheumatoid arthritis, for instance, and in end stages of burnt-out chronic hypersensitivity pneumonitis. So the individual histology doesn't necessarily give us the diagnosis. And I think, again, this was borne out in this paper here, the great and the good of the American Thoracic Society and ERS came together to look at the phenomenon of idiopathic NSIP, and in doing so it became clear that actually the diseases change over time. So what at point of diagnosis appears to be an idiopathic condition does, as you follow it with time, declare itself to be a connective tissue disease, for instance, or an altogether separate condition. Oh, good. And furthermore, we've got this issue that even when you take the very best pathologists, we struggle to always categorize the pathology effectively, and the same is true of CT scans. And so whilst we use multidisciplinary meetings as our gold standard for diagnosis, we're still left with a rump of patients in whom we can never truly achieve a diagnosis, and so we don't have great diagnostic gold standards. And I just put together this slide, which is very fuzzy, that just shows that the different diseases associate with the same pathologies over and over again. So we need perhaps better ways of classifying our diseases. So what other problems do we have? Is there a way to predict disease progression? When we see a patient at diagnosis, we don't really know how their disease is going to behave. And you'll have seen this graph come up before now. Hal and Talmadge put this together. And we see patients who can have a very indolent disease progress. They can be diagnosed with IPF and they can live for 7, 10 years after diagnosis. On the other hand, we have the patients who we all recognize who, from diagnosis to death, may be little less than 12 months. And then we have the group of patients in between who are relatively stable but then have these catastrophic acute exacerbations. And so I've just got some CT scans to illustrate this. This is a patient who presented in the January, and by the December, you can see that his fibrosis has progressed rapidly. This next patient was a lady who was playing golf in the spring. She presented with mild breathlessness, sort of climbing the steep hills towards the final holes. And actually a month later, when she reattended, that was her CT, and she had an acute exacerbation that she died of within 4 weeks of initial presentation. And yet we're not able to discriminate these patients when we see them at diagnosis. The next challenge, we've already heard about some of the pathways involved in the pathogenesis of IPF. One of the great strengths of this meeting is that we hear about everybody's very different and specific interests. But if you're trying to think about it from a drug discovery point of view, which of the pathways that we're going to hear about over the next few days are the key ones that we should be targeting? And actually, we almost have an embarrassment of riches when it comes to potential therapeutic targets in IPF. So this is a schematic, my thoughts on the pathogenesis, that this is an aberrant wound healing response, that when we get injury in the lung, by whatever means, we activate multiple wound healing pathways, And this initially leads to sort of development of the provisional matrix, an influx of fibroblasts, upregulation of profibrotic mediators, and in the normal wound healing response, you should then get in the later phases switching on of antifibrotic mediators that lead to clearing of that matrix and restoration of tissue structure and function. And for some reason in IPF, it all goes wrong at this stage, and we get too many profibrotic mediators, not enough antifibrotic mediators, and we get perpetuation of the fibroproliferative response. And so picking which of these mediators is the most important, which are just downstream effects, and which are the upstream important drivers of disease is very difficult. And for this reason, this is why we probably have a drug pipeline that looks like this. We have a multitude of different compounds that are in various phases of clinical development. Many of them are very exciting, but if I asked people in the room to lay a bet on which they thought was going to be most successful, we would probably have an even split across all of them, because there's no way of identifying which of these individual targets is best. So the next challenge, obviously we want to see these targets translated into therapies for patients, and yet we don't have a very effective translational pipeline in IPF. One of the difficulties we have is that, first of all, trying to validate our targets in vitro and validate target compounds in vitro is challenging, but also designing the small early phase studies that would give us the confidence to move on to late phase studies is very difficult. We lack surrogate measures. I'm sure those in the room are aware there's been a heated debate about best endpoints in IPF studies, but we're still talking about studies that need to be at least 12 months long, and whether that's powered for FVC or other endpoints, it's still a very expensive business to deliver a phase 3 study in IPF. And the literature is littered with small early phase studies with small numbers of patients. So this is gamma interferon, published in 1999, got everybody very excited. And yet we know a decade later that it's ineffective. And so we really, as a community, need to find a way to be able to identify the key drugs that are likely to have an effect without needing to move to massive phase 3 trials for each potential compound. And finally, will a single treatment be effective for patients with IPF? It seems unlikely. It's a paper or a perspective that Carlo published with others a couple of years ago, drawing parallels between IPF and cancer biology. And as I've already alluded to, IPF is undoubtedly a disease of multiple pathways, and it seems likely that in different individuals, different pathways will predominate. And so a single treatment is unlikely to be effective for all patients with IPF. And if we look to the cancer literature, we can see that over the last decade, they've come on leaps and bounds in stratifying disease. And so they can now develop molecular phenotypes for individual tumors, and they can gauge prognosis and also best therapy based on that molecular phenotype. And I just take this as an example of one of the papers in the literature and a treatment approach that's emerging, and something I suspect we will move to once we begin to get more therapies through to clinic in IPF. So how can we address these problems? Well, I think taking a step back, as we've already heard, there's an awful lot we don't understand, and the more we understand, the less we realize we understand. And I think when we were at medical school, we learned that transcription and translation from DNA through to protein was a very simple business, but actually we now realize it's much more complicated. We've got epigenetic modification, we've got the microRNAs, we've got post-translational modification, we've got the microbiome, and we've got the whole of the host response to disease and environmental factors that ultimately drive disease phenotype. And so trying to understand what causes any one condition requires us to integrate all these different aspects of the biology of the host and the environment that surrounds them. And I think a number of disease areas are now moving towards this idea of disease fingerprinting, so integrating omics-type information, genomics, epigenomics, and you could add in plenty more like lipidomics and metabolomics. We then need to combine that both with the clinical phenotype at diagnosis, but also importantly the longitudinal behavior of disease. It's not enough to say this patient has IPF, but there's also important information that's gained over time in seeing how the disease behaves. And only in integrating all that information can we really come up with a comprehensive understanding of the individual condition. And I put this up as an example of how things might develop in the future. So this is the lebrikizumab treatment in asthma. So it's an anti-IL-13 antibody developed by Celgene. And you can see that they've used periostin levels to be able to pull out a group of patients who respond better to therapy. So we're already starting to see personalized medicine within respiratory. And I suspect this is how we will begin to move in IPF in the future. So where do we stand at the moment? There have been an increasing number of biomarker papers in IPF. Naftali and the Pittsburgh group have done a lot of the work, and this is their paper from earlier on this year. And they've identified 5 serum proteins that predict longitudinal event-free survival. And those are the proteins there, and this is built on some of their earlier work. It's worth saying that these are point of diagnosis blood tests, so that they haven't looked at longitudinal changes in serum markers. There's also a couple of other very good papers in the literature. So this Anjay Pras's paper on CCL18, again showing that levels of CCL18 at diagnosis predict subsequent outcome. And this is Anjay Muller's and Martin Kolb's paper on fibrocytes, again showing that fibrocyte levels, if you dichotomize them, also predict subsequent outcome. Naftali's group, again, with Moises Selman and Ali Pardo, have looked at gene expression profiles in IPF. So this is RNA from whole lung homogenates. And there's a number of themes that have come out. First of all, they've compared IPF with NSIP and hypersensitivity pneumonitis, and you can see that IPF and hypersensitivity pneumonitis are clearly very different. And then the NSIPs, some of them are IPF-like and some of them are hypersensitivity-like, suggesting that gene expression may provide us insights into diagnosis that histology doesn't. And similarly, that they've looked at whole lung homogenates from patients with rapidly progressive disease versus slowly progressive disease and seen differences. But as a diagnostic tool, this is limited by the need for lung tissue. So where can we move to next? So this is now to describe the work that we've started doing in the UK. And so Richard Marshall, who's worked with GSK and is well known to this meeting over many years, is probably the sort of author of this group. We've put together a collaborative with all of us working between academia and industry, trying to understand the disease better. And so we have ourselves at the Brompton, working with Nottingham and Gisli Jenkins, UCL with Rachel Chambers and Robin McNulty. We've also got McMaster with Jack Goldie and Martin Kolb. And then we've also got some other fibrosis institutes looking at other organ fibrosis. And having brainstormed some of these problems that I've described to you, we designed the profile study as a way of trying to answer some of these questions that I've raised. Can we better understand the disease? Can we integrate all the elements of our knowledge of the disease biology and come out with the tools that might better equip us for studies in the future? And so this is the study that we've designed. We're prospectively enrolling patients with a diagnosis of IPF based on ERS ATS criteria. We're also including patients with idiopathic NSIP. We're then seeing them at baseline, 1 month, 3 months, 6 months, 12 months, and then yearly thereafter. And at each visit, we're collecting a range of blood samples, serum, RNA. We're also collecting a series of clinical measures, and where possible, we're getting lavage at baseline as well. And we're repeating each of these measures over time. And so between us, we've been reasonably successful at recruiting patients. At the Brompton, from a tertiary referral population, we've now recruited in the last 18 months 115 individuals. Gisli, drawing on a series of secondary care hospitals across central England, has now recruited 152 from Nottingham. So we're running in parallel the same protocol between the two sites so that we have reference populations to compare. And as you can see, despite our population being tertiary, they're overall very similar to the secondary care sort of patients being seen in the Nottingham area. And so we've sent off our first batch of serum for analysis. We're measuring proteins mainly through multiplex assays, but also using bespoke ELISAs, and I think we're measuring 115 serum proteins in total. And these proteins have mainly been picked through our knowledge of the literature, proteins that have been tried as biomarkers before now, and also potential targets of interest for the future. And so we've sent off samples from the first 100 patients recruited into the study, and I'm afraid I'm not going to give you all the answers today, but this is principal component analysis that's been undertaken on all those proteins, and it just demonstrates very nicely, first of all, that we're seeing a difference between healthy controls and patients with fibrosis. So overall, the blood protein signature tells us the disease is there, but CT does that as well. More importantly, however, the red dots and the green dots discriminate the Brompton and the Nottingham cohorts, and actually we're not seeing any difference between our cohorts, again giving us confidence that between the two sites we're including patients with similar disease. And this is one of our early readouts for MMP7, so this is a biomarker that Naftali has validated as a point of diagnosis predictor of outcome. And we've measured it at baseline. We have the 1 month, 3 month, 6 month values. Each line follows an individual patient. Here we have the group mean with the box and whisker plots. And as you can see, we lose numbers because as a longitudinal study, by the time we sent off the blood samples, we didn't have everyone out to 6 months. But you can see that generally there's stability in the signal, and we have a team of statisticians working to look at firstly what that signal means in terms of predicting future outcome, but also what change in that signal over time means for the individual patient. And then obviously we've got the challenge of integrating the 115 proteins together and trying to answer the same questions with all of them in the mix. So perhaps at next meeting I'll tell you more. And so in terms of predicting disease progression, one of the things we've looked at in-house at the Brompton is the relationship between telomere length and progression of disease in IPF. And I have a personal interest in cell senescence and its role in IPF pathogenesis. And I won't go into the telomere story in too much depth because I think we'll hear about it more later on today. But suffice to say, individuals with IPF have been shown to have shorter telomeres than healthy controls. And so we took our first 70 patients and looked at their telomere lengths. And as you would expect, with the patients, the older patients have shorter telomeres than the younger patients. If we look at telomere length and baseline disease characteristics, so baseline FVC or baseline composite physiological index, we don't see a relationship with telomere length. But when we start to look at the longitudinal data, when we start to look at both 6-month decline and 12-month decline in FVC, we start to see an important difference. So those patients who have progressive disease, both at 6 months and 12 months, have significantly shorter telomeres than those with stable disease over that time. Another area that we're looking at is the sort of interaction between the host and the environment, and the microbiome in both health and disease is gaining sort of increasing awareness. We realize that the lungs aren't the sterile environment that we were perhaps taught they were at medical school, and the novel sort of molecular techniques are allowing us to probe the microbiological community in different organs in much more detail than we've ever been able to do before now. And so this is work in collaboration with Bill Cookson and Miriam Moffat at Imperial College, and we have a shared PhD student, Phil, who's got a poster that people can interrogate him about tomorrow. And we've taken lavage from 55 patients now, spun down the cell pellets and looked at the 18S RNA to look at the microbiome and the microbial populations there. What we see, this is it doesn't come out wonderfully well, but this is a heat map of those bacterial communities, and we're seeing bugs that aren't necessarily associated normally with either IPF or normally cultured in IPF, and Phil can give more details at his poster tomorrow. But again, what we're seeing, if we start to look at the patients with stable disease versus those with declining disease, is that in the patients with progression, There's loss of microbial diversity, which again in other diseases has been associated with poorer prognosis and outcome. And as with the protein work, we're sort of doing the computational analysis to try and allow us to integrate the clinical phenotype with the microbiological phenotype. And again, I think there's interesting data there to tease out over the coming months. And then the last bit I'm going to touch on is improving longitudinal phenotyping. So traditionally, we see patients on a sort of 4 to 6 monthly basis. We repeat the lung function when we see them. And so our understanding of their disease is based on that sort of regular interval of medical follow-up, and we sort of neglect what happens in between times. And so we've developed a project as part of the profile study to look at handheld spirometry and whether that allows us to predict disease behavior in more detail, and whether it perhaps allows us to pick up exacerbations at an earlier stage. Particularly if some of these exacerbations are caused by bacterial infection, it gives us an opportunity to intervene before the exacerbation really takes hold. So we've given 40 of our patients handheld spirometers that they take home, and they do daily FVC readings. We also ask them to complete a weekly D12 questionnaire about their symptom score. We find that, and we are being slightly selective in who we pick, but the patients that we pick are well-motivated, intelligent individuals, and we find that they perform their spirometry very well and very reliably, and the correlation between the handheld FVC and the FVC performed by our lung physiologists is very good. There is variability day to day. This is everybody all together, looking at the first 3 months of data, and it's a bit of a mess presented like that. So I'm just, again, for the purpose of this, pick out a few interesting cases that we've observed. So this is the standard behavior for the 40 patients through the first 3 months of home spirometry is generally to have very stable lung function, although when you do the linear regression on all the points, you find actually across the population there is a very subtle decline, even over 3 months, on the daily values. This individual is one of the few that's been doing it that died, and essentially he went from being well to dead about 3 months after starting with a handheld spirometry, and he struggled to do it after the first 3 weeks because he was becoming more breathless. But you can already see there's a different slope to his line, and we hope to understand this slightly better as we recruit more patients into the study. This is another interesting one that gives us hope that handheld spirometry might be useful. So this patient here developed a cough with green sputum. They started their breathlessness scores, as measured by the dyspnea 12 index, started to increase here, and they were given a short course of antibiotics, and I must confess steroids, and actually you see a very rapid improvement in their vital capacity, and actually the symptom scores lagged behind, so it took until here for their sense of breathlessness to return back to baseline, but the FVC actually recovered quite quickly with prompt treatment of infection. And so we hope that we can build a sort of monitoring technique for these patients whereby we can pick up early infection using handheld spirometry as a tool to do that. So, to conclude, IPF is a complex multi-pathway disease. I think at the moment, the steps that take us from identifying targets through to a phase 3 clinical trial are still poorly mapped out, and there's a lot of work to do to improve that. And we've got a lack of validated endpoints that allow us to run those short, early proof of concept studies that would, I'm sure, help deliver many more treatments to the clinic. Our study, the profile study, is recruiting very well, and we're excited about the longitudinal data that we're generating, and I look forward to presenting that in the future. And I'm very optimistic that integration of omics data with careful longitudinal disease phenotyping will allow us to understand this terrible condition so much better. So all it does is remains for me to thank those that have helped with all of this. So Anne-Marie has been my research nurse who has recruited a lot of our patients. Josefa was an ERS fellow who did a lot of the work on telomere length. Phil's been doing the microbiome work. Gisli has been heading up the Nottingham side of things, and Gori and Rebecca have been doing the hard work of recruiting patients. And then GSK have been incredibly supportive of the whole endeavour, as have our collaborators at McMaster and UCL. Thank you very much.
Good talk. Thank you very much. We have time for questions. Oliver?
Thanks, Toby. Just let me challenge you with one question. Do you feel at this point where you are with the study that the inter-individual variations in serum biomarkers, you showed NLP7, was difficult to see from the back, is small enough to give you distinction between groups?
I think that's one of the interesting questions we hope to answer. I think if you look at the literature thus far, actually very little work has been done to truly validate individual biomarkers. So we don't understand day-to-day variability or longitudinal variability, nor do we understand how specific and sensitive the assays that we're using are. So I think all of that has to be teased out and are important parts of trying to understand the value of these proteins.
And at this point, you're comfortable or not?
Reasonably.
How do you diagnose exacerbation? Do you phenotype them? Do you collect blood to look at biomarker during exacerbation?
So I think that speaks to an important problem. Obviously, we have the ATS-ERS definition of an acute exacerbation, which is very robust, but it's also very stringent. And actually, very few of our patients who feel symptomatically worse, who have deterioration in vital capacity, necessarily fulfill a true ATS-ERS definition of acute exacerbation. I think the other difficulty we have with that definition is that it excludes all infection. And I think infection is as important as an idiopathic or cryptogenic exacerbation. And so I think we still have work to do as a community as to how we exactly define exacerbations, how in the community we can define it better. And again, I'm sort of hopeful that by doing this longitudinal study we can tease that out, because in reality I think we've had about 2 ATS-ERS acute exacerbations, but we've had many more acute deteriorations, either due to infection or where they haven't quite ticked all the boxes.
Toby, that was great, thank you. I guess I'm going to ask the same question in about 30 different ways, but it all comes back to the use of the patient as their own control, and how successful have you been, I guess, in getting tissue samples and using the actual lung tissue to inform the blood biomarkers. So, and then the surrogate question is how willing, I guess, have people been in donating the lungs once they've died, and again using the tissue to inform the blood? Yeah.
And in terms of tissue, we biopsy far fewer in the UK than are biopsied in the US. Certainly in Naftali's biomarker study, 60% of them had tissue biopsies. We're down at about 10% with ours, but we've been successful in collecting biopsy samples from those patients. At the Brompton, we have the difficulty of being a national referral centre, so it's very hard for us to get autopsy specimens, but Giesli has managed to put in place a protocol in Nottingham, so I think you've collected a small handful so far of patients' lungs, and we find that our patients are incredibly willing and generous, both with their time and with biological samples, and in contemplating donating samples after death. And I think it's important that we try and tie that together, and we make the most of our patients' willingness to try and understand this disease better.
One question. One of the problems in these type of studies is the final outcome.
Yeah.
Why? Because, okay, the patient died or goes into transplant. And usually the patient that goes into transplant is not that sick and it's in a much better condition. How do you deal with these problems?
Sadly, our transplant program in the UK is less responsive to the needs of IPF patients than the American transplant program, and we haven't had anyone transplanted yet, so it's not an issue.
I'd like to ask again if there are any questions in the other room, and we have another question in the back. If you could get the microphone back there. And while you're doing that, I have a couple of questions. One is, you mentioned you were getting BAL from some of these patients, and I'd like for you to comment on the utilization of BAL versus blood samples for your biomarkers, and whether you think that the BAL might offer some advantages or not. And then secondly, with the telomere data, what we find in our cohorts, both the familial and sporadics, is that about a third of them have short telomeres in the absence of telomerase mutations that we can identify. So that's led us to wonder whether the short telomeres were a cause or a result, and I wondered if you could just comment on this longitudinal change. It's very interesting that you see differences in progressors and not in telomere length, but I wonder if there might be a group that has a rapid or more rapid decline in telomere length, and are you going to get at that with this data?
Fine. So a lot to cover there. So lavage, I think, on paper and theoretically offers a very attractive window to the lung, and it would be, I think, wonderful to try and find proteins there, and certainly as part of it we're looking at the same protein arrays in lavage as we are in serum and plasma. The challenge comes with the difficulties of interpreting dilution and variable return that you get with lavage. So I think there are still hurdles to overcome in how you normalize the data to then get value from it. And I don't think we within our study group, but also we as a respiratory community, have fully addressed that issue. Your question about change in telomere length over time, so we haven't yet done that. Those were telomere lengths at presentation. I know there are studies from other disease areas, so in cardiovascular disease, that suggest that accelerated telomere attrition is associated with worse outcome, and I think it's an important question to ask in IPF as well.
Thanks, Toby. These are elderly patients with many comorbidities, so how do you correct for the various comorbidities, and not all of them with comorbidities, as we see in COPD, would die from IPF?
Again, it's been a challenge for the statisticians. We're trying to integrate all the clinical data, so we have a huge clinical data set as well that tries to integrate comorbidities, co-prescribed medications, and put that together with also the important markers of IPF disease severity and progression. And I'm not sure there's a simple way to try and handle that, but we are trying to tease it out through the sort of careful statistical handling of each of those variables. At the end of the day, however, we want a pragmatic result that relates to the patients we see in our clinic rather than an idealized young patient with no comorbidity. So whilst I think it's important to take it into account, I think it's also part of the reality of IPF patients. They have comorbidities, and so any result we get, we want to be translatable to the normal IPF population.
Thank you. I believe we do have some questions from the other room, so if you could go ahead.
Toby, this is Paolo Spagnolo. And my question is, I've seen that you've been collecting the DNA samples as well. So how are you planning to tackle the genetic component of IPF, if you think there is one? I don't know, looking at polymorphisms in candidate genes or genome-wise association studies? Because in theory, genetic could give you tremendous information in terms of pathobiology of the disease. Excellent talk. Thank you.
Thank you, Paolo. I think the question you raise about genetics is a very important one. Again, it's part of the trying to integrate all of the information that we can have. I think with the genetics in particular, we probably need even larger patient sets than we have. And I think it's something we're keen to collaborate on with people with other DNA collections. So I think that should be part of an IPF community effort to try and understand the genetics better.
I believe we have one final question in the other room.
Yes, thank you. I was very fascinated by your work on the home monitoring of FVC, and I wonder if your FVC data correlate with your questionnaire score. You might have said that, but missed it. Thank you.
It does, but it seems that the FVC and the questionnaire tell us slightly different things, and we're trying to understand that at the moment. It's not quite a straightforward linear relationship, and there seems to be a slight disconnect between patient perception of symptoms and sort of objective data in forms of FVC, and we're trying to tease that out. And there is some suggestion that they both give us prognostic information, that a change in symptom score alone is important and should be a sort of a marker that the patient's disease is changing. And sometimes it may be more sensitive than the FVC alone, but I think we need more than our 40 patients to try and work that out.
Okay. Thank you very much.